Welcome back, everyone, to this comprehensive explainer. Today, we're delivering a university-level masterclass designed specifically for the advanced clinician, and we're focusing entirely on the algorithmic approach to hypercalcemia. We're going to completely bypass the basic physiology you already know and jump straight into a high-yield, lossless transformation of diagnostic pathways, clinical phenotyping, and acute casualty management protocols. Let's get started.
We've got a packed agenda today. We'll be moving from classifying presentations to the IPTH algorithm, then diving into parathyroid-dependent disease, parathyroid-independent mechanisms, radiographic findings, and finally, crisis management.
All right, let's kick things off with Section 1, Classifying Hypercalcemia and Presentations.
So let's get perfectly precise right out of the gate. Our normal adjusted total calcium sits tightly between 8.6 and 10.3 milligrams per deciliter. Anything greater than or equal to 10.5 milligrams per deciliter is our rigid biochemical threshold for hypercalcemia, and that requires an immediate evaluation. Now, for those of you dealing with varying international units, just remember the exact conversion. 0.25 millimoles per liter is equal to 0.5 milliequivalents per liter, which equals exactly 1 milligram per deciliter. Etiologically speaking, you need to mentally prepare for a classic 80-20 split. Roughly 80% of these cases are going to be parathyroid dependent, while the remaining 20% will be parathyroid independent.
We've all heard that classic medical school rhyme, right? Painful bone, renal stone, abdominal groan, psychotic moans, and fatigue overtones. And while the psychotic moans part definitely makes for a memorable catchphrase, clinically, the long asymptomatic phase is technically the most common. But when symptoms do finally surface, fatigue is the dominant overarching presentation. It's also absolutely crucial to remember that acute gastrointestinal presentations can closely mimic pancreatitis. However, diarrhea and seizures are distinctly uncommon in this setting, so you should actually use those as specific exclusion clues on your differential.
Looking beyond the obvious symptoms at the systemic exclusions and catch points, we see a fascinating cascade. Hypercalcemia distinctly drives nephrogenic diabetes insipidus, which results in profound polyuria, severe dehydration, and subsequent prerenal acute kidney injury. Electrocardiographically, we see the classic short QT interval. Physically, you've got to watch out for pseudoclubbing. And the trick here is that, unlike true clubbing, the Lovibond angle is perfectly maintained. Finally, on a chronic level, this manifests as chronic kidney disease driven by tubulointerstitial fibrosis, which is very frequently accompanied by hypokalemia and hyperuricosuriا.
Moving right along to Section 2, the IPTH Diagnostic Algorithm.
The physiological rule here is incredibly straightforward. High calcium should suppress PTH, period. Against a normal reference range of 50 to 100 picograms per milliliter, an intact PTH, or IPTH, greater than 50 in the setting of hypercalcemia indicates a profound lack of appropriate suppression. This definitively locks us into a parathyroid-dependent etiology.
Conversely, what if that number is deeply suppressed to less than 20 picograms per milliliter? Well, that points aggressively to parathyroid-independent etiologies. The second you see the suppressed number, it must trigger an immediate, rapid search for malignancy.
Now, mapping out these distinct biochemical profiles reveals definitive clinical signatures. Primary hyperparathyroidism, which is usually an adenoma, gives us high calcium, low phosphorus, and high PTH. Secondary hyperparathyroidism, classically a CKD response, is actually a low calcium, high phosphorus, high PTH state. But tertiary hyperparathyroidism, that represents a physiological breaking point. Prolonged secondary stimulation in CKD eventually leads to gland autonomy and nodule formation, resulting in high calcium, high phosphorus, and a massively elevated PTH, frequently soaring well over 1,000.
Okay, Section 3. Let's look at parathyroid-dependent clinical phenotypes.
Let's anchor this with a classic clinical vignette. Case 1. We have a 60-year-old female presenting with recurrent calcium oxalate stones, a calcium of 12, and an unsuppressed IPTH of 212. This is the prototypical primary parathyroid adenoma. The localization study of choice here is the technetium 99M Cestabee scan, capitalizing on the delayed washout of oxaphyll cells in the adenoma, which, by the way, is most commonly located in an inferior parathyroid gland. In your differential, you absolutely must account for MEN1 and 2A hyperplasia, lithium use, and carcinoma linked to CDC73 or parafibromin mutations driving hyperparathyroidism jaw tumor syndrome.
We really cannot discuss the parathyroid without contrasting two vital pediatric pearls. First, familial hypocalciuric hypercalcemia, or FHH.
This is an autosomal dominant loss-of-function mutation of the calcium-sensing receptor, presenting with mild hypercalcemia but remarkably low 24-hour urine calcium. We have to contrast this with Jansen disease. Jansen disease is a gain-of-function mutation of the PTH type 1 receptor. These patients present with severe hypercalcemia despite a very low, entirely suppressed PTH, and they suffer from short stature and metaphyseal chondrodysplasia.
That brings us to Section 4, Parathyroid-Independent Disease Mechanisms. Dissecting our second case, we have a 6-year-old male with severe fatigue, an ESR of 100, high calcium, and crucially, an IPTH of 18. This beautifully illustrates humoral hypercalcemia of malignancy via PTH-related peptide, or PTHRP. PTHRP operates on PTH type 1 receptors and potently suppresses native PTH. This is the single most common tumor mechanism for hypercalcemia and is overwhelmingly associated with squamous cell carcinomas of the lung, head, neck, and cervix.
But what if a malignancy isn't immediately obvious? Then we pivot our algorithmic lens directly to the vitamin D pathway. Case 3 involves a 20-year-old male presenting with an acute abdomen and medullary nephrocalcinosis. By properly testing both forms of vitamin D, we find a normal 25-hydroxy-D3, but a profoundly elevated 125-dihydroxy-D3. This isolated elevation points directly to ectopic 1-alpha hydroxylase production. The prime suspects here are non-caseating granulomas and sarcoidosis, as in our specific case, as well as lymphomas and acromegaly. Grouping our final parathyroid-independent pathologies together, let's look at Case 4. Extreme dehydration and bone pain in a patient with breast cancer. This highlights osteolytic hypercalcemia driven by direct bone metastases, which is also very common in multiple myeloma. To round out the differential, never forget the endocrine triggers like Addison's disease, pheochromocytoma, and thyrotoxicosis. Keep milk alkali syndrome in mind, and pharmacologically speaking, remember that while loop diuretics cause hypercalciuria, thiazide diuretics actually cause hypocalciuria, thereby exacerbating the hypercalcemia.
Next up, Section 5, Radiographic Findings and Sequelae.
We must be incredibly precise with these skeletal findings because their radiographic signatures are entirely unique to the disease process of unregulated parathyroid action on cortical bone. The absolute most characteristic change is subperiosteal resorption, uniquely seen on the radial side of the proximal and middle phalanges of the index and middle finger. Moving centrally, you will see the classic Rugger Jersey spine and the salt and pepper skull. You'll note acral osteolysis and endostele scalloping. Finally, the disease culminates in osteitis fibrosis cystica and those classic brown tumors, which, by the way, are not true neoplasms, but rather hemorrhagic, osteoclast-driven masses of debris.
And finally, Section 6, Crisis Management and Surgery.
When we're dealing with a primary parathyroid adenoma, medical management is frankly obsolete. Surgery is the only curative mandate, and this is confirmed intraoperatively by a rapid drop in PTH levels. While all symptomatic patients unequivocally require excision, the precise indications for asymptomatic surgery are strictly defined. They are age under 50, evidence of renal failure, a 24-hour urine calcium greater than 400 milligrams, documented osteoporosis, or a serum calcium greater than 1 milligram per deciliter above the upper limit of baseline.
Now, when a patient presents in an acute hypercalcemic casualty crisis, your sequence must be immediate, and it must be aggressive. Step 1. Establish 2 IV lines and initiate IVC-guided aggressive fluid resuscitation at 300 to 500 milliliters per hour to counter that profound nephrogenic DI dehydration. Step 2. Administer rapid-acting calcitonin at 4 units per kilogram subcutaneously twice daily, but use caution, as tachyphylaxis reliably occurs within 2 to 3 days. Step 3. Lock in the slower definitive mechanism with an IV bisphosphonate, preferably zoledronate, dosed at exactly 4 milligrams in 50 milliliters over 15 minutes.
We also need to clarify some highly nuanced pharmacological caveats here. Glucocorticoid steroids have a highly specific role. They only work in osteolytic and vitamin D-dependent hypercalcemia. They do absolutely nothing for parathormone-dependent disease. Loop diuretics are no longer recommended as routine practice by major societies. Denosumab definitely exists but is strictly framed as second-line therapy. Finally, agents like gallium nitrate, plicamycin, and mithromycin have zero current value and should be considered entirely obsolete.
To synthesize the key facts from this masterclass, Primary parathyroid adenoma is the most common overall cause of hypercalcemia. However, the most common cause of a severe, acute hypercalcemic crisis is osteolytic metastases from breast cancer. And, from a tumor mechanism standpoint, humoral hypercalcemia via PTHrP from squamous cell carcinomas is the undisputed most common paraneoplastic driver.
As we conclude this explainer, I want to leave you with a provocative thought. Given our rapidly deepening genetic understanding of familial hypocalcuric hypercalcemia and the calcium-sensing receptor, could we eventually manipulate this receptor pharmacologically with such extreme precision that we entirely replace the scalpel for primary hyperparathyroidism? It's a truly fascinating frontier to ponder. Thank you for joining this masterclass. Keep questioning, keep learning, and we'll see you in the next one.